I think you are live now.
I'll tell you, sir. I'll tell you.
Yes.
I'll go
And
live,
the
say two
recording
words and hand
also,
over to
Samshu.
Anas, sir.
Should I enable recording? So the recording has started.
Please start the recording, sir.
Okay. So we are on air now.
Yes, we are on air.
Great. So start.
I'll tell you. Please wait.
Go.
Kumar, you put up my presentation, right, Beta?
Yes, I have.
We are on air, Samshu.
You're here?
Yeah.
My microphone is lit. So we're starting, sir. Good evening from Author TV side. Today we are going to organize BOA's foot and ankle webinar. So now I request our BOA president, Dr. Manoj Chaudhary, sir, to say a word.
Hello. Dear audience, delegates, and faculties, I, Dr. Manoj Chaudhary, President, BOA webinar on ankle and foot trauma. And the webinar is blockbuster webinar on foot and ankle injuries. And the topic of discussion is what went wrong and how to salvage. We have esteemed panelists from India and abroad. And I am very thankful for their participation, their cooperation, and their contribution. This is an interactive session, and you may participate in it by asking questions to Shamsul or other way. Something I would like to add, and this is that we have many ankle and foot trauma surgeons here in Bihar, in India, and they are very much skilled, and you will witness their skill in this program. I had requested Dr. K.S. Anand, Kumar Santanu Anand, to have one very good webinar on foot and ankle trauma, because he is dealing with foot and ankle traumas. I think he is a very good surgeon, and you will see this in this program. And he has made this program. This is his planning, and you will find that this program is very useful to us. Thank you, K.S. Anand, for such a nice program. Thank you.
Now request our secretary, Dr. Rajavan, sir, to say a word.
Good evening, all of you. I'm Dr. Rajiv Anand. It's a matter of great pleasure that we are starting our third webinar and the first webinar on foot and ankle. And on behalf of Bihar Orthopedic Surgeon, I welcome all the guests, all the faculties, and all the viewers who are in air today. And since foot and ankle is a real subject to be learned, and this time I really welcome our Dr. Arvind Puri from Australia, Dr. Gau from Singapore, our national faculty, Dr. Rajiv Shah from Baroda, and Dr. Rajesh Simon, Dr. K.S. Anand, and myself, and a lot of thanks to Dr. Samsul and Dr. Ashok Shyam. So without wasting much of your time, today the session will be moderated by Dr. K.S. Anand, and we'll be covering all the possible foot and ankle injuries So over to Case.
Right, sir. So, without much ado further, it's my proud privilege to be here as a moderator, and I'll try to do the best that I can. We have a galaxy of stars in ankle surgery, including Dr. Urban from Australia, Dr. Bob from Singapore, and our national luminary like none other than Dr. Rajiv Shah sir and Dr. Rajesh Simon. So I'm here to act as a moderator. So may I invite as our first presenter, Dr. Arvind Puri from Cairns, Australia.
Well, thank you very much, Anand. And thank you also for inviting me and organizing this webinar with your team at such a short notice. The topics are definitely very interesting, and I'm sure all of us will have lots to learn from it. And I must also thank you, Kumar, for letting me speak first. I'm probably the closest to the timeline. Now, we can start by bringing up my slides first, Anand.
Right. So can you see them?
I can. If you start at the very beginning there, please come on.
Oh, sure.
So I'm going to be discussing two cases that I've got on Pilon fractures. Now, I think all of us are pretty familiar with these fractures. They are becoming an increasing incidence, both from road traffic accidents and from other injuries, and we all have to deal with them very, very carefully. This is a fracture that can really make your life miserable if you don't treat it with great respect. I think in the past, people have learned a very hard way of how this fracture, if the soft tissues are not really dealt with respectfully, can land them into a lot of trouble. So as you all know, we all are pretty much guided by the principle of prevention is better than cure. And I thought my first case would be something which perhaps avoids me getting into trouble so I don't have to end up salvaging it. So the first case that I have is that of a 48-year-old male who's an itinerant farm worker, a chronic smoker and a drinker who jumped off the pub wall and ended up getting the fracture that you see here on the x-rays. So Kumar, were you keen to get the discussion rolling from here?
Right. Sure. So as you rightly pointed out, when I saw this X-ray, the first thing that came to my mind, oh my God, there has to be something very wrong with the soft tissue as well. So I asked Dr. Rajiv Shah sir that when he sees such an X-ray, what is the first thing that comes to your mind, Dr. Rajiv Shah sir?
Yeah. Number one, I try to judge whether this is a case where it's a low velocity injury or it's a high velocity injury. Again, history also tells me. And the important thing would be that what is the status of the soft tissues. And that is what is going to guide the management.
True.
Obviously, when we see such a case, we'll think of looking at the skin condition and then either following span, scan, plan, and perform, or scan, span, scan, plan, and perform, which is the today's trend.
So I totally agree with you, Rajiv. That is exactly how you should go in that order and in that stepwise, carefully looking at the soft tissue. As we all know, the soft tissue around this part of our anatomy is not very great. There is hardly any soft tissue covering. It's all tendons, subcutaneous tissue, and then the skin. And this guy, because he jumped off from the wall of a pub, is a high energy injury, and he had marked swelling and tense skin, and he also had some altered sensation in his foot. So with his background of having been a chronic smoker, an alcoholic, we thought that maybe we should try something different here to give him a good outcome without landing him in trouble, along with that us. And so as a first step, we went and we put an external fixator on him to get this fracture reduced out to length as best as we could, and have the position somewhat in the ballpark of where it should be. Can I have the next slide, please? This is just a slide to show the degree of comminution that he had at his articular surface of the distal tibia. So while he was waiting for the swelling to come down, we had a really hard thought, and I know there is this possibility and presence of doing percutaneous fixation for these kind of patients. And knowing that he was not going to give up any smoking and he was going to go back to the alcohol as soon as possible, we thought we should try to do as a minimal an approach as possible. So as soon as the skin looked reasonably comfortable at around day 5 to 6, we took him back to theater, and then under image guidance, what we did was percutaneous
No.
reduction.
Wait a moment.
Okay.
May I ask Dr. Rajesh Simon that the patient has now been taken to OT. What would be your choice of fixation, and what would you like to have in your armamentarium? What implant you'd put for a definitive fixation?
Thank you. This is definitely underestimated when you look at the X-rays, and when you see the CT scan, the real pattern appears. So can I have the other, do we have other CT pictures?
No, that's all I have there. I'm sorry, Rajesh.
All right. So I just want to see.
I want to make it difficult for you.
Yeah, anterolateral part, the extension is what I was looking at, an anteromedial and anterolateral. We can see the elevation here. I mean, the articular part is quite elevated in the tibial side, but I don't know where the fracture pattern is. But
so
I would be planning, I will have all the plates, the anterolateral as well as the medial plate to start with. Prefer to have an anatomic plate today when we have this locking anatomic plates.
So I agree with you, Rajesh, because that would be the standard way to approach it, is to deciding on the pattern of the fracture, what approach you're going to use. So the principles, as you know, are that you want to decide based on the pattern, are you going to get fixed the fibula or not? If there is a fracture, this guy didn't have it. Are you going to fix the tibia from the back, from the anterolateral, from the anteromedial, or do you believe in doing just one anterior approach and dealing with everything? So essentially, that is the right way of a standard acceptable view of dealing with this fracture. But you know, we do have patients who are diabetics, vasculopaths, people on steroids, chronic smokers, and I myself have had quite a few patients with that background where my wounds have given me a lot of trouble to look after these patients. And I've become more and more careful as to how much dissection exposure I do. And if I can get away with minimally invasive surgery, I'm going down that path more and more now. Now, I don't have a very long follow-up of 10 years, what happens to these patients, but my short-term follow-up is not that bad. So you're quite right in that approach. But what I did was, and I'll show you in my next X-ray. Can I have the next slide, please, Kumar?
I'm trying.
Okay.
Something, it is stuck up, so give me a time. Give me a moment.
So you can try the right and left key, sir. The arrow key. Use the arrow keys.
Arrow key. Yeah, no, I'm not able to do that. Okay, just give me a moment. You carry on with the discussion. Just give me a moment.
So, you know, the X fix that we put, that just got our alignment and, you know, a reasonable kind of reduction of the bigger fragments, but the articular surface was certainly not reduced. So we had to make small incisions on the anterolateral side and try and push the fragment, which was the anterolateral fragment, down with the help of, you know, like flat osteotomes, narrow periosteal elevators, punches, just to get as far as we could push down the articular surface and the anterolateral. Once we had the reduction, what we thought on the image intensifier reasonably acceptable, we then made small percutaneous incisions and then fixed with some screws from front to back, lateral to medial, and medial to lateral. And at the end of it, it was reasonably acceptable with not a huge step in that. And we left the frame on for 6 weeks. Then we put him in a below-knee cast, non-weight bearing, for another 6 weeks, and at 3 months had a CT scan done to make sure there was adequate healing before we allowed him to put weight. Now the wounds healed pretty well, and at the end of the day, he's had a reasonably good outcome with moderate range of movement of his ankle, and he's reasonably pain-free, back going to his pub with no problems.
Right. So I'm able to now go forward. So if you want me, I can go forward with the other case.
Yeah, but if there's any other
we-
issues or points, yeah.
Why
Can
did
we,
it
can we have the AP view, please?
I don't have it here. I'm sorry. I just put, because I was told to put as few images as possible, I've put that one there so that the articular surface could be seen.
Right.
Why you think about a neutralization plate in such a bad pylon plate with why not neutralization plate?
As
Why
in, when you say neutralization plate,
yeah,
so,
I mean, why did you think about continuing with an external fixator? You could have put a neutralization plate within in a minimally invasive way, MIPO way.
you could have, I agree. But with this character, the kind of patient that he is, the only way we make sure he comes and sees us for regular pin check dressing is to keep him in the X-Fix. And to me, the X-Fix, yeah, these are kind of things you have to take into consideration when you're dealing with patients of a certain, perhaps social and economic background. So for this man, we got the alignment right with the X-Fix, right? So he was more or less straight in both planes, and we got the articular reduction reasonably well, and he ended up being healing up quite all right. So I do agree, a plate would have been easily put on, but I wanted to really use the minimum incisions possible to give him as good a reduction and hold it there and let nature just heal it up as good. I still believe having a really good soft tissue envelope is so important for these fractures to heal.
Yes.
And I think that is what probably helped us in letting this guy go on to healing at the 3 to 4 months mark.
Right. So keeping in view the time also, let's go forward with the next.
Sorry?
There we go. Should I put another case of yours?
Yeah, definitely.
So there you go.
Yeah, now this one is the one which I got into trouble, and so I had to depend on a few simple ideas to try and salvage it. So this is another Pilon fracture in a guy who's about 50 years old. He's employed. He is a non-smoker, and he fell off a ladder while at work, landing with axial impaction, resulting in this Pilon fracture. Now, this was also a grade 2 open with a wound on the medial side where the tibia was through the skin. Now, the CT scan, the next slide, please.
Okay, right. Yeah.
Yeah, the next, yeah, that's it. So that gives you an idea of the comminution, impaction at the metaphyseal, diaphyseal junction and the degree of comminution in the articular surface. And he also had, as you could see on the previous X-ray, a fracture of his fibula as well. So as on day one, he went to theater for a standard washout, debridement of his wounds, and X-Fix was applied. And at that stage, I thought it would be a good idea for me to just plate his fibula to get him out to length and then come back later on and fix the rest once the swelling has subsided and hopefully infection was not a big problem. I used the posterolateral approach to fix his fibula because I knew I wanted to come back and fix the posterior fragment through that approach as well. So I waited for about 12 days before I thought the swelling was good enough. He had had his antibiotics. The wounds were looking not too bad. The medial wound was also looking like it'll heal up all right. And so at that stage, I went back, put an through the posterolateral approach, put a plate at the back. And because he had so much comminution as well as impaction of his metaphyseal fragment, I was quite sure he would end up going into varus. And so I put a medial plate as well for him. So if you look at...
So allow me to little
Sure.
again. Yeah, right. So what Rajesh said, what Rajesh said, probably you'll put in practice in this particular case, not in that one.
Yes, the standard practice of X-fixing, fixing the fibula, waiting for the wounds to get better, waiting for the swelling to come down, planning on the CD scan what approaches you're going to use and what plates you're going to apply. So I did exactly that.
Can I have a comment onto this, Kumar?
Sure.
Sure.
So the typical notion of doing a fibular fixation together with external fixation
Yes.
at the first juncture is now questioned in the recent world. I would go in and fix primarily fibula, provided that fixation is not going to come in the way of my future surgery. Provided that is one. For me, primary fixation of fibula with the X-fix indications are: number one, this fixation of fibula is not going to come in the way of my future fixation. Number two, the fibular fixation, fibula is not so greatly comminuted for me not to get a good reduction. And number three, that I'm sure that I will be the next surgeon doing this surgery. So if these three criteria satisfy, then and then I would wish to go in and do primary fibular fixation.
Because he had such a lot of comminution and it was unstable, the fibular fracture was comminuted as well. The only way I could give the soft tissues the due respect it deserved for it to swelling to come down and wound to heal was to at least fix the fibula and just stabilize the lateral side and put an X-fix and let the length and alignment be as best as possible. And with the wound on the medial side, I didn't want to put anything on the tibia at all. And I made sure I used the posterolateral approach, which would not interfere with me putting a plate at the back when I come back in 2 weeks' time.
No, Arvind. When you put a plate posterolaterally first on the fibula, when you come next for doing posterior malleolus fixation, the fixed fibula is going to come in the way of you looking at the reduction of the posterior malleolus. So you could have just gone with the external fixator.
On the lateral side through the posterolateral approach.
Right. So right. So
not at the back of it.
All right. So maybe the question really here is to fix the fibula at the first instance. I mean, while you're putting the X-fix, to fix the fibula or not, right, Rajesh sir?
Yes, exactly. Let's have the panel.
Yes. So that's a very, very important question. There's a very important question. So may I invite Gauz, because he hasn't spoken so far on air. So Gauz, my friend from Singapore, could you please come up with your views?
Yeah, thank you, Kumar. I just take an opportunity to say thank you to all the panel and Niha Orthopedic Association for inviting me over. So rapidly moving on, I think it's a very, very good point that's come up. I think the conventional thinking by Elgawa that we plate the fibula, we put in a medial plate on the tibia, get it out to length, bone graft it, is the rule that applies to all Pilon fractures. We now know is no more true. In fact, I would go forward to say, just like Rajiv has said, that there are very select cases that actually need a fibula plating in the first instance. In fact, in my practice, I would only plate the fibula if there's virtually no comminution at all. And I am genuinely concerned about the soft tissues. So I feel that if there is a sitting where I have to wait for 2 weeks or 2.5 weeks, and I'm very sure about the approach that I'm going to use for the second stage, i.e. I already have a scan, I've planned the approach for the second stage before I do the first operation, only then would I plate the fibula. In other words, what I'm trying to say, it's almost better to just scan and span and leave it, and then come in and do the fibular fixation with the tibial fixation at the second stage, whether it's 7 days, 10 days, 14 days, in my practice, even up to 17 days before I do the second stage.
Right. So let me tell you all that we already have more than 1,000 viewers live, and I'm really grateful to each one watching us. So that's a message that's going to all my viewers, all our viewers, that the scenario and the ideas are changing, and fibula may not be, as a rule of the thumb, be fixed at the time of external fixator application, it depends upon so many other factors which has been enumerated. Is that right, Rajiv Shah sir?
I also want to add one point.
Yes.
So whenever you are putting an external fixator in a pilon fracture,
Yes.
always draw your probable incisions which
Yes.
you are going to take in the second sitting, and then put your pins so that your pin should not come in the way of your next approach which you are going to take. So that also should be taken care of.
So right. So moving forward, should I move forward with the next what Arvind has done?
Yes.
Yes, Arvind, are you there?
His audio is muted.
Oh, I see.
Do you hear me?
Yes.
Yeah.
Right. So I'm glad that this point was brought up with the fibula plate, because that is why I landed up in trouble. Right.
Right.
So at my next stage, I fixed the back with the plate posteriorly, and because there was a lot of impaction on the metaphysical part of the fracture, I didn't want the fracture to go into varus, and the impaction is mostly due to the fact that I got the fibula out to length. And so there was this gap on the medial side, and to prevent the fracture from going to varus, I, in my smartness, put a plate on the medial side because the wound was pretty good. And I was quite happy with the fixation. But, you know, because I had lengthened the fibula to its right level, the impaction and loss of bone on the medial side was held with the plate on the medial side. I landed in trouble. So after a few weeks, around the 8 to 10 week mark, his wound on the medial side started to ooze, and he had developed cellulitis. So he had obviously got now an infection along with delayed union at the tibial side. The fibula, of course, was healing quite all right. So I had to then go back in, open the wound on the medial side, take the medial plate out, and you can see the CT scan here. There's no union at all at the tibial side, and there's a big gap on the medial side. There is some hint of callus on the lateral. So I had to go back in, take the medial plate out, and put some cement beads to try and control infection. I followed the standard protocol of taking all the tissue, soft, bony swabs, got a bug, put him on antibiotics for 6 weeks. And then at 6 weeks, I had to plan my next step as to what I was going to do. So I'll leave it to you, Kumar, to see if you have any questions at this stage.
All right. So that was a very good case for learning. And a very important point came that as a rule of thumb, the fibula doesn't need fixation. Your first case also showed that it depends from one case to another. You have to take into account factors like whether the patient is a smoker, patient is a diabetic, and what is the socioeconomic status. So you have done miss there, almost minimum method there. Whereas in this case, your approach is entirely different. So probably the message that we all can take from this is that we have to really individualize our treatment plan suitable to each individual patient. I think everyone would agree to that. Anything to be added here?
My question to Dr. Puri is that did you feel any difficulty after fixing the fibula and then again going to fix up from the same posterior lateral incision? So did you feel any difficulty to reduce the posterior part of the tibial fracture?
No, the posterior, no, it wasn't difficult at all. In fact, my biggest issue was that there was a big gap on the medial side. And I had to accept it and to try and prevent any varus deformity, put a plate on the medial side. But I had no problem. With the X-fix and the fibula, the posterior fragment was pulled down pretty much to where it should be. So all I was really doing was stabilizing that fragment. I didn't have to struggle a lot with it. Right. But you know, when I had done the whole fixation, I had this deep feeling that that medial side just didn't look right to me. And I was going to protect it from going into varus, but I had the deep down that there might be something to stop the healing from progressing. But you know, I was forced to go back and take the plate off just because it developed an infection around that 8-10 week mark.
Right.
So, you know, his subsequent CT scans also showed that he had non-unions. So at the end of it, after 4 to 6 weeks of his antibiotics, I had to go take all the beads out, bone graft the medial side, which wasn't healed after curating it, and he ultimately went on to union then.
Right.
So it was a
Arvind.
long process.
Arvind, did you corrected virus while you did the bone grafting?
No, I just jacked the bone graft right in there.
Okay. So
Yeah.
I would have gone in with the dissection on the medial side with the lamina spreader and put in a iliac crest graft, stud iliac crest graft, so that together with the gap filling, I will also make a part, something like a supramalleolar osteotomy to correct the varus.
Yeah, no, I just opened it as much as I could and I packed it because it's only mild degree of varus, and we can accept about 5 degrees maybe or less. So I accepted it.
Ankle will not accept varus. It will accept valgus.
Yeah,
and unless you
I
do
know.
the long-standing X-rays, you really do not know how much varus is there.
Yeah, true. I agree with that. But I mean, I don't have the full tibia view here, but you will see that the varus is minimal. It's not a lot.
Okay.
Right. So I think we should move on to the next presenter because we are already at half an hour into our webinar. And so should I now invite Dr. Rajesh Simon with his cases?
Shantanu sir, you should stop sharing first, sir.
I have to.
Okay. Yes. There I go. Yes.
Yeah.
Meanwhile, he's sharing. There is some echo at Dr. Arvind's end.
Okay.
Just mute it.
So good evening, everybody, and thank you, Bihar Orthotics Association, for granting us this platform to come across this type of case presentation. I'm sure when we learn from that cases, we learn more than the theory. So here I have a 24-year-old male who came to me with pain and difficulty in walking for 1 year, and he was otherwise a healthy guy with no other comorbidities. So history-wise, I would now just go as a little bit of a history and talk. This was a history of patient 1 year back. This was X-ray taken 1 year back. The physician or the surgeon, whoever it was, saw the swelling around the ankle, got the X-rays of the ankle, and said there is nothing wrong, must be soft tissue contusion, and gave him a baloney slab. The patient was uncomfortable after 2 weeks, and he removed on its own. Since there was no fracture, he was said everything was good. He removed on his own the plaster, but the pain and swelling and the difficulty in walking kind of was there. So after about 2 months, now this is the one point which I would like to say here. Are you guys all happy with the X-ray?
No.
Would any one comment, just one comment on what would be doing differently, just for all the viewers?
So I think there is a large diastasis or gap between the tibial incisura and the fibula. I would want a mortis view, and I would get a CTA in retrospect.
Perfect. So that was a keen eyes. The tibiofibular overlap or the tibiofibular gap is slightly altered. Ideally, more before all this, a mortis view. So the 3 views, AP, lateral, and mortis view is important, one. And second, which we all learn in trauma series, try to take the whole limb X-ray. You got to see the joint above and the joint below. So ankle injuries, try to take the whole limb X-ray. So he goes to another orthopedic surgeon after 2 months, and that person was a little more wiser, and he took an X-ray. Now this is what was missed. If oblique fracture of fibula a little higher up from the ankle, which was missed on the first X-ray. Now the second mistake happened was he said no further interventions required because the fracture is healing well. So this is what happens after about 2.5 months, and the fracture is healing well. The patient goes back happily, but the pain persists and he just cannot walk properly. In a year's time, this has worsened and it was very difficult for him to get walking. So then he goes to a third orthopedic surgeon and an MRI was done. The MRI says there is a fibular fracture which is healing. There's a high-grade ATFL tear, partial, all those, you get to know all this MRI pictures from all the radiologists saying the syndesmotic injury, etc., etc. And so the third orthopedic surgeon decides to fix the syndesmosis because the syndesmosis is disrupted. And after he puts the screw, he couldn't find the medial gap space which was increased. So he opens up the medial side, repairs the deltoid ligament. The subluxation persisted, and so he puts a K-wire. I would like the opinion of the house now.
Well, it is too late, too little.
Yeah, definitely. Great point. One sentence. Too little. So yeah. The problem was the fibula was looked at the lower part and not completely looked up after. The syndesmosis was not reduced properly, and hence the subluxation of the ankle persisted. Just by putting one K-wire there would just not help here. So secondly, if you look at the screw itself is not right. It was a lax screw. They had tried to do a compression at the fracture site. So again, that is a mistake. So this is where they come to, the patient comes to me and I remove this, so the K-wire was removed and the ankle again subluxates, and that is when they come to me.
If you allow me, Rajesh, I'll just stop you here for a while. Pardon me for that.
Yeah, sure.
I'd just like to have the views of Dr. Rajiv Sasser, Gao, and Arvind about the fibular overlapping, because we also need to correct the length of the fibula. So I can see what I can see. There is some overlapping of the fibula. So unless we correct that, we are not going to really get it in a proper way. So my question to all my three eminent panelists is, what do you think about the fibular overlap here? Is it correct, or they need to correct this?
So before I start answering your question, some important points which we must note are sound clinical examination.
Yes.
A simple clinical examination of a squeeze test or an external rotation stress test would have shown that there is a tenderness at the level of syndesmosis. As Dr. Rajesh said, getting 4 views of the ankle would have been very, very important. And the most important notion which Paul Tornetta poured into all of us is that any damn fracture in the ankle would have association of syndesmotic injury. So our suspicion should be very, very high to rule out syndesmotic injury in every fracture. May it be Weber B, may it be Weber C, may it be Weber A.
Yes.
So these 2 points should be kept into the mind. And now coming to the comment on this axis, the syndesmotic screw is placed through the syndesmosis, which has to be placed 2.5 to 4.5 centimeter above the syndesmosis. Now, if
before that, allow me to barge in, sir.
Please.
Before that, what would you say about the fibular overlap? Are you happy with that?
Absolutely not, because unless you restore the length and rotation of the fibula, which is fibula is externally it is shortened. Unless you restore that, you're not going to get the congruity. So that should have been restored. So anything else you want me to answer further? How would I manage, or you want others' view?
I think we'll have the other view also. Anything else, others?
Yeah, I'll chip in a little bit more beyond what Rajiv has said. So talking about syndesmosis, again, this is a fracture personality that should have a high index of suspicions that, almost a sort of a variant of a Maisonneuve, a high ankle sprain type injury where the fracture force goes through the deltoid, through the interosseous ligament and exits at the fibula. So at the point of diagnosis, again, clinical exam, tenderness at the fracture site, tenderness over the medial gutter should have actually warranted further imaging and stabilization. Coming back to your very specific question, Kumar. So again, with the syndesmosis, people talk about rotational instability. People talk about antero-posterior instability, which is in the coronal plane. And of course, in this particular case, you have what is known as vertical instability. Yeah. So when we try and restore syndesmotic integrity, we always plate the fibula. And by plating the fibula, we hope that the vertical instability is restored. So in this particular situation, the fibular malunion, if you like, or the shortening of the fibula has resulted in a degree of shortening and therefore vertical instability. So the fibula doesn't have a fighting chance of sitting in incisura. And so the talus will always be anteriorly translated in relationship to the fibula, and that reduction will never ever be possible unless the fibula is put back into the incisura. And that would involve restoring length, restoring rotation, and also ensuring the AP translation is restored.
Right. Thank you.
I think it summed it all well. So this is what I did. I just removed the X-Fix, and I could find the hind foot is a little kind of laterally shifted. Otherwise, there is no signs of any infections. The movements was restricted. And obviously, his main complaint was he couldn't weight bear. And that was the X-ray after I removed the screw. And now you can understand that is what all the panelists have said. Yeah. The medial joint space is increased. The fibula is shortened. The talocrural angle is altered. The tibiofibular overlap and the clear space has been disturbed. The movements in the lateral side, you can see a little bit of subluxation. So that is what the fibula, you should understand the amount of importance of fibula in the ankle. It's not what we've been taught that the fibula in the first 10 centimeters, it is anywhere the shortening happens, you're going to have a problem. It is not that old teaching which we all learned that fibula, you should look only at the distal part, just above the syndesmosis. Now with this case, the whole idea is to understand you have to look at the leg, the whole length of the leg, not at just the ankle part, even though the patient came only with the ankle pain.
Beautifully said, right.
So my plan was, in between I had done an MRI done to see the ligaments part also, and there was a lot of muck in the anterolateral gutter and the syndesmosis area. So my plan was to do an arthroscopy, debride the joint, debride the syndesmotic scar, which has been there for 1 year. Again, get the fibula back with a distraction osteotomy, bone grafting, with, as Dr. Rajiv had said, about iliac graft here, and a syndesmotic repair with a tightrope. And when you lengthen it, you also have to understand that the gastroc gets tighter. So I did a gastroc recession. So this is what I did. Just to make it shorter, I have not gone into detail, just the immediate post-op, you can see the iliac crest graft here. I did not go all the way to the original fracture site. I thought it was too proximal. So I went down there. You don't have to go all the way down there. You just have to look at the mortise. So just lengthen the fibula at this level, just above the syndesmotic area. And then I used 2 tight ropes to get the syndesmosis. Once I got the length of the fibula and the rotation of the fibula corrected, the mortise automatically fell in place. The distal fibula pulls the talus properly, and it automatically reduces, the ankle automatically reduces. And then I just had to put 2 tight ropes from the plate to get the syndesmotic fixation rightly. And this is how.
Simon, I'll just ask you one question. Go one back, please. Go one back, please, Simon. Yes, my question is to you as well as to every panelist, to Arvind, to go to Rajiv Shah sir, as to ensure that there is a perfect fitting of fibula into the incisura. Would you, in such cases, open and visually examine as to whether it is fitting into the incisura or not? That is my question.
Yeah. So I'm going to answer that question, but before that, whenever you are approaching such cases, you need to open medially, you need to open laterally, you need to open syndesmosis.
Yes.
That is a must.
Okay.
But I don't look at the reduction. I don't look for the reduction at incisura, because
Okay.
Paul Tornetta came up with the studies that 64% of the cases of ankle had different varieties of incisura. It was found to be convex, concave, flat. So I like to look at the reduction at the joint line. I want to see the joint line, not the incisura for the reduction. So Kumar, always look at the joint line, not at the incisura. Look for that Mercedes-Benz sign.
Right.
So that's one. Now, if you allow me to do one more comment.
Yeah, sure, sir. Please go ahead.
This was a neglected case. And
Yes.
tomorrow I am doing a webinar for Indian Foot and Ankle Society on to neglected ankle malunion. I would not like to use a tightrope for a neglected case. For a neglected case, I would almost use a stronger implant, because all said and done, if you go back to your x-rays, there was some bony kind of feeling, bony kind of things. If you can go back, I can show you. So this, yeah, there was something which was between the two. Something in the syndesmosis. So this is almost always going to land into synostosis. So you need a stronger fixation. And for a malunited cases, I have almost always used tightrope. A tightrope, I have screws over tightrope.
Right.
Here, my only advantage was I did spend quite some time in opening up the syndesmotic area with a scope. So I could debride a lot of scar from there. And once I was kind of happy with the scar, I mean, the advantage with scope is you can see all the sides, the medial and the lateral, and go all the way up towards the syndesmosis, because there is no syndesmosis here except for some kind of scarry tissues. So it was easy for me to go all the way down. So that is why, and still I agree with you, and that is one reason why I put two tightropes instead of one. To get more.
Now, if you are putting two tightropes, the studies have shown that they should not be put in the same direction. They should be put into 30-degree direction. I think, Dr. Gom, what is your viewpoint about the latest studies?
Thank you, Rajiv. So I'm going to be devil's advocate, and I will start off by saying that this is actually a very difficult operation. Having unfortunately done this twice before, I think firstly, debriding the syndesmosis is very, very difficult. In this particular situation, getting rid of all that bony exostosis and making sure that the fibula falls back into the position at the level of the ankle, I think is very difficult. In my experience, when I've done it, I've had to pin the fibula, the distal fibula at least, in the correct position before stabilizing the syndesmosis. Now, I would actually, contrary to what Rajiv said, I would veer on the side of the tightrope. And I'll tell you why I would do that. Tightrope, as we know, is a little bit more physiological. It allows for a little bit of dynamic physiological motion. And in this particular situation, if trying to get the fibula into the correct position is very tricky. And if we pin it with two screws in the wrong position, then that affects the ankle biomechanics completely. Even if we visualize the syndesmosis and we pin it in the right position, it will be very tricky because subtle motions of rotation or translation will affect the ankle motion. So, and finally, to concur with Rajiv, I completely agree. The studies have shown that if you're going to put two tightropes, it has to be in a convergent fashion. because then it gives you the stability in at least 2 planes, which is what the tightrope is based on. And on that note, again, with syndesmotic stabilization, the onus now is not to compress. We don't want to put big clamps and compress the joint. And there's also increasing evidence that we don't need to dorsiflex the ankle. Ideally, you want to keep it neutral or just have it supported so that you don't tighten up the syndesmosis. So I would go for tightrope. I would say it's a difficult operation. And I would say convergent fashion for tightrope stabilization.
Thank you so much, Go. There's a question for you, Simon.
Yeah.
And it is from none other than our dear friend, Dr. Pradeep Munot.
Hi, Pradeep.
Yeah. So Pradeep is asking, how did Rajesh make sure the fibula was reduced properly? Did he open the joint medially? I think that's a very good question from a very good foot and ankle surgeon, Dr. Pradeep Munot. He's asking, how did you make sure the fibula was reduced properly? Did you open the joint medially?
No, I did not open the the joint medially, but I did not show the steps here. Like Dr. Go said, I did pin the fibula distally and kept the distractor so as to, and radiological, it was more of a radiological assessment, but then I did open up. If you can look at my staple area, the staples have been put, it is a large opening, and so I could visualize the syndesmosis to a certain extent from clear the proximal part, but no, I haven't opened the medially completely. The medial staples, what you see is more for the tightrope plates, not for opened medially. No, I haven't opened.
Right. Thank you so much. Now to sum up this case, I'll just make this comment. The theme of our webinar is what went wrong and how to salvage. That is our theme. So I'll request you, Simon, to go to the first X-ray and scroll quickly and tell us in short what was wrong. Why exactly was it wrong? I have the impression that the surgeon, the index surgeon, really did not understand, or rather he took it very lightly, did not take the proper X-rays, did not do the proper fixation.
I'll make it up. I have already done that. So this is how the final thing was, and this is now about 1 year, and he's okay now. So the takeaway tips was point number 1, as we started, always take a full-length X-ray and try to take all the 3 views.
Right.
And most importantly, as Dr. Rajiv Shah sir said, that clinical examination is of paramount importance. If you think there is no obvious fracture in the X-ray and the ankle is swollen up, always look at the ankle, look at the syndesmotic area, and be suspicious about it. So high degree of suspicious is always important. So point number 1, clinical examination and the proper radiological investigations. Point number 2, the second surgeon looked at the fracture of the fibula. He did not look at the ankle mortise. Had he looked at the ankle mortise, he probably would have intervened. He looked at the fracture fibula and he said, wonderful, the fracture is healing good. So always realize that, especially when you're looking at an oblique fracture of fibula, there is a shortening, and when there is a shortening, the ankle mortise is always disturbed. So that's point number 2 is the moment you see the oblique fracture of the fibula, look at the ankle more suspiciously. Right. And number 3, as we've been saying, syndesmotic fixation is with a positional screw. The site of the fracture should be above the syndesmosis, that is about 3 centimeter, 2.5 to 3 centimeter. It's a positional screw. You have to use a fully threaded screw, not a partially threaded screw, because this will act like a lag screw. So you don't want compression. And so that is a faulty syndesmotic fixation. And finally, when you find there is a persistence of subluxation, when you find there is a talar tilt is not corrected, then you should always realize that the length of the fibula is not achieved. At times it is difficult intraoperatively when you're doing it C-arm. So your suspicion, you have to be looking at it. And so in ankle, always remember, fibula is a key anatomic structure. Talus is attached to the lateral malleolus. So the moment you pull it down, talus falls in place. A malrotated fibula is not obvious on all the views, but you got to look at it. But malaligned fibula leads to a malaligned ankle.
Right. There's another question, Rajesh, from one of the viewers. Before we conclude, may I ask you that question? Hello, can you hear me?
Yeah, go ahead.
Yeah, the question is from one of my dear friend, Dr. Samir Imam. Dr. Samir Imam, who is asking, he has written, whether vertical stability for fibula would also be addressed, even if it is higher near the fibular head. Probably what he is asking is that in your case, the fracture which was missed in the first instance was somewhere a little just below the middle of the fibula.
Ms. Novis, that is what he's asking.
Yeah, so suppose the fracture is quite higher up near Maslow. Yes, yes, please come. And that's
yeah, so this is what I think Dr. Govard already said about the vertical instability.
Yes.
What we have to look at fibula is the not at the site of the fracture. At times nowadays, even if it is a mid shaft and if it is not very comminuted, I just put a small wire through it just to keep the length. The length is very important. So higher up, the rotation of the ankle joint is not very affected unless it is a very bad pronation external rotation injury. Otherwise, the length is very important, and the lower down the fracture fibula, the rotation also is gets more important. So yes, if it is at the neck and it is reasonably in position, the length is not very altered, you can just leave it alone. But if it is altered, then you have to look at the length of the fibula wherever the fracture is.
Right.
Simon, one question from me. How did you assess that how much length you have to increase by putting the graft?
Excellent question, sir. So
yeah.
This is why I didn't show the steps of the X-ray of the surgery, but I did use a retract on the laminar spreader.
Yeah.
And with the pins above, fixing the distal portion of the fibula to the talus, when the more you do the lengthen, and then when the whole thing falls in place, that is one. And pre-operatively, I also had my comparison X-ray of the normal side, which was a guide to me. So the two steps were helpful in getting the length.
Thank you.
This case is you should be painting and draping both the lower limbs.
True, sir.
Yes.
And the lateral X-ray of the opposite side of the ankle should always be on the view box. And third point is that whenever you are lengthening the fibula, 2 wires to be put from proximal fibula going into the tibia, so that you lengthen only the distal part.
Very, very good points.
Right. So thank you very much, Simon. That was an excellent case. And going on with the flow, may I now invite my friend from Singapore, Gauri Santhavendran. Let me tell all my viewers that Go is also the scientific committee chairman of SICOT, and he is a very eminent foot and ankle surgeon from Singapore. It's really a pleasure to have you here. So, with your first case.
Thank you, Kumar. Again, thank you very much for the invitation. Dear panelists, thank you for having me. And to the 1,300 viewers who are watching as well, thank you for having me, and greetings from Singapore. Can I have the first slide, Kumar?
Yeah, I'm trying.
So I'll give a background as to why I chose these cases. We are talking about difficult cases and salvaging the ankle. This wasn't a case of salvage itself, but this is a case that could have easily gone into an unsalvaged.
Can everybody see my screen? I'm sorry. Can everybody see my screen?
Yeah.
Yes.
Great.
Sorry. So this is a case that could have gone into an unsalvageable situation, and hence that's the rationale for highlighting this case. So it's a case series of two cases of the similar pathology. The first is this 81-year-old lady on a cruise ship. She had tripped about 24 hours ago, and she had come into my hospital emergency department. This was an isolated injury, and she was actually very well otherwise. Background wise, she's very independent, very active. She was on a cruise after all, going from Hong Kong to Bangkok. And she was referred as a close injury. Her leg was very swollen. Pulses were present. And she had already had one attempt at a manipulation under sedation in the emergency department before I was contacted. So moving on to the second slide. So this is the X-ray taken at the point at which she had come in. So you can see on the lateral view, this is a short of a better way of describing it, a fracture dislocation of the ankle joint with at least an obvious disruption of the distal fibula and definite loss of integrity on the medial side as well. Okay, I'll just stop there, Kumar, for a second. And perhaps if you want to open it to one other panelist to say, is there anything particularly concerning on this X-ray at this stage?
Yes, I'll invite the views first from Arvind. And hi, Arvind, are you there?
I am.
Right. So may we have your views, please?
So can I just have that X-ray back again, please?
Sure. Just a moment. Sorry about that. Yeah. Can you see? Hello?
Yeah, I can. Yeah. So there is, as Gao has said, there is the fibular fracture. There is, as expected, quite a bit of osteoporosis in here. There is comminution as well. And I have a sense that there is another fragment, which you can see on the lateral view, which is on the posterior aspect of this fracture. And then in the medial side, there is also some comminution. Is there something happening at the subtalar area as well? I'm not able to distinguish that from the X-ray that I've got.
Yeah. Arvind, I'll just interject at that point. So this is the X-ray taken after the first reduction done in the emergency department, at which point I'd come in to assess the patient for the first time. I'll just move on and show you the next slide. Kumar, we just move on to the next slide. So this is after the second attempt at reduction. And this is actually done by myself. And I was actually quite surprised with this position. Now, at this stage, is there anything that kind of raises any red flags or any concerns apart from the obviously malreduced ankle?
So in my experience, Gao, when we have had posterior fragments taken off, usually the reduction is very, very difficult. It just wants to slide back into that posterior sublux position. And it's quite difficult to just hold it with a back slab or anything of that sort. And in my cases, if I've found that I cannot reduce them, I would put an X-fix on these guys.
Okay, so you would take them to the OR at this stage?
Yeah.
Okay, I'll just move on, Kumar, to the next slide.
Yep.
We'll stop at that juncture for the first case, and I'll illustrate the second case. This chap is a lot younger. He's 28-year-old who had gone just across the border to Malaysia on an ATV group excursion, fell and sustained a close injury to the ankle, closed injury, transferred back to Singapore on the same day, later in the evening. On examination, arrival, closed injury, neurovascularly intact, but very deformed looking ankle and swollen, but compartments were soft. We'll have the next slide, please.
Yeah.
Now, again, this was his X-ray after the first reduction. So again, this chap had had a reduction in the emergency department, and I was contacted at this point. There are some striking similarities. between this case and that. The ankle is still mal-reduced with an obvious posterior translation of the talus. But again, on the AP view, you see a widening on the medial side and a distal fragment. Kumar, you want to open up the discussion to another panelist to ask if there are any other tips or red flag signs?
Certainly. So I'll invite the views from Dr. Rajiv Shah, sir. Hello, are you there? Just let me see. I think he's there.
Yeah. Okay.
Right.
Now I'm in. So whenever you have an injury where there is much rotational force involved with a very small size medial malleolar fragment and a very big displacement like what you are seeing, you must suspect some soft tissue interposition.
Yes.
And if you are not able to reduce, then you might have to, proceed for surgical intervention.
Rajiv, I'll interfere at that point. Can you elaborate a little bit on when you say soft tissue interposition, which structures in particular are you worried about?
I'm worried about the capsulo-ligamentous structure on the medial side. I'm also worried about, with this kind of a fracture, I'm worried about tendon of tibialis posterior getting interposed. So all anteromedial capsulo-ligamentous structures, I'm worried about getting interposed into this.
Okay. All right. We'll move on to the next slide, Kumar.
Yeah, sure. There you go.
So at this point, for me, the concerns were you have an ankle that has had a attempted reduction twice and is not reducing. The patient has a very swollen ankle, and so you're worried at the background about an evolving compartment syndrome. And as Rajiv has pointed out as well, the culprits, if you like, is this a bony incarceration, or is this some kind of soft tissue interposition? So I'll show you the next slide. So this, I'll tell you exactly what happened, but we can stop at different stages and you can question and perhaps we can clarify why certain things were done. So the patient was kept nil by mouth. As soon as the second reduction was attempted, an emergency operating theater slot was booked and she was consented for an open reduction fixation. Also for exploration, KIV repair of soft tissue structures, ankle arthroscopy. And the thinking at this stage was, obviously, firstly, there's a high risk of intra-articular injury from this ankle. But also the thinking was, if I put a scope in at the start and I see anything inside the ankle joint, which is hindering the reduction, then it would actually help me with where to make the open incision. I also counsel the patient on potential risks, including nerve injury, vascular injury, and delayed compartment syndrome. Because again, with this sort of prolonged swelling and deformity, you're worried about a progressive compartment syndrome.
Sorry about interjecting here.
Yes, go ahead.
Yeah, but since I'm the moderator, I have all the powers, don't I? Right. So my question is to other panelists as to how often they encounter similar situation where they are not able to reduce such displaced fracture even by second attempt. So my question is to Rajesh Simon, Dr. Rajiv Shah, and Arvind.
This is not a very common scenario wherein you have an impingement of the soft tissue, but yes, it comes once in a while. I've had one lately wherein I also had the associated talar fracture along with the bimalleolar. So it can happen, as Dr. Rajiv Shah was saying about the small fragment of medial malleolus, wherein you can have your tibialis posterior or the deltoid coming in between. So it is not a common thing, but when it doesn't come, keep in mind to kind of open reduce and get the ankle. You don't have to fix the ankle. You got to get the ankle reduced. That will help the soft tissue, and then you can put the X-fix and come out and wait for the soft tissues to settle down. But you got to reduce the ankle. That is the key point here.
How
So
many?
Kumar.
Please, yeah.
So in my experience, apart from seeing bony tissue within the ankle joint, which stops it from reducing, the ones that I have encountered are the ones who've got a big posterior fragment, a lot of avulsion of the interior capsule, where you just can't hold those ankles in a reduced position. And I've had to take them back in and put them in an X-fix to keep them reduced and come back at a later date and then fix them.
Right. Okay, so do we go ahead?
Yeah, so I just want to say something before we move to the next slide, Kumar. So again, a mal-reduced or irreducible ankle joint in the setting of a fracture is actually very rare. In the vast majority of cases, we can reduce it. We may not be able to hold it reduced, but often there is a subtle widening of the medial clear space or even of the talar shift, but it's usually reducible. And so in this particular situation, when you have a virtually completely dislocated ankle, it's actually exceedingly rare. So this is a red flag sign, and it's something that, you know, we should immediately prompt taking the patient to the emergency OT with a view to trying to reduce it under a general anesthetic. So I'll show the next slide, Kumar.
So yeah, so I guess this is a special subtype of a special fracture, a specific type of fracture, which is entirely different from those fractures which are reducible but get dislocated, and reducible and get dislocated, but this one was not being able to be reduced in the first place, right?
Yes.
Okay, so there you go.
So I'll start off by apologizing for how busy the slide is, but I wanted to put all the information on one slide. I'll just draw your attention to point. So basically it's a supine position. I started off with an ankle scope. Now the rationale for that is obviously before the scope and muscle relaxation, under GA and muscle relaxation, I tried to reduce the ankle and have fluoroscopy to assess it, but it wasn't reducible. So I then proceeded with a quick ankle arthroscopy. It was just 10 minutes to look into the ankle joint to see what I could find, to try and plan whether I should start with a medial incision or whether I should start with a lateral incision. And I couldn't see anything in the ankle joint. It was actually quite clear, apart from the fact that the ankle was obviously subluxed. So I started off with a posterolateral approach to the fibula with a view that I needed to fix that. And oddly enough, the fibula was noted to be displaced very much posterior to the tibia. There was no real interposing soft tissues, and the laminar spreaders was used to reduce the reduction. But once I was able to get the incarcerated proximal fragment of the fibula back onto the distal fragment, and this whole two fragments were noted to be very, very mobile, then the entire ankle reduced back into position. So it was an issue where the fibular fragment was actually sitting incarcerated or blocking the reduction of the tibia back onto the top of the talus. And I'll show you a picture after this to clarify exactly what I'm talking about. The syndesmosis was visualized in the same setting. I put a clamp in because it was very loose, but I never clamped it when I fixed the syndesmosis. And finally fixed it with a tricortical fixation. Can we have a next slide, Kumar?
There you go.
So this is the picture taken for the first ankle, the 81-year-old French lady post fixation. And can I show the next slide, Kumar?
Yep.
And this is the second ankle. This is the 28-year-old IT engineer who had it fixed. So again, it's a plate fixation, nothing different from our conventional fibular fixation with stabilization, in this case with screws. Can I show the next slide?
Before you go forward, can I ask one question?
Yeah.
The question is that the plate you have used here, of course, you had to fix the syndesmosis as well, so you have used the plate in this direction. For the purpose of the benefit of viewers, could you have used a plate on the posterior surface of fibula, like an anti-glide plate, and put two syndesmotic screws separately or something separately?
I didn't particularly feel I had to. I think the fracture pattern wasn't one that particularly required an anti-glide plate. It was more of a buttress plate, getting the fibula out to length and neutralizing it. So I put the plate at the position where it's seated best to serve as a buttress and as an as a neutralization device. And the screws admitted itself quite nicely from the fibula onto the tibial position. So I think to answer your question, I think it's feasible, but I didn't have to do that in this situation. Can we show the slide before this, Kumar?
Yeah, sure.
And even in this situation, the plate stood pretty much a direct lateral. In fact, with this, the approach was almost direct lateral. It wasn't actually a posterolateral approach. And it admitted the screw quite nicely. I must say, I tend to stabilize my syndesmosis almost always with a tight rope. But in this particular situation, I chose the screw because cost was an issue.
Okay.
And tightrope cost about $1,200 in Singapore. And so I elected not to do that in this situation.
It's not very
Kumar,
easy.
Kumar,
Yeah.
can we go to next slide? I have a question to Bob.
Yeah, there you go, sir.
Yeah. So, Dr. Go, are you happy with this, with the direction of your syndesmotic screws?
Yes, I am. Are you saying it's a little bit too low?
The direction.
Direction.
The direction, yeah. Yes, I think it's fine.
Ideally, it should be parallel to
Parallel
the.
to the.
Yeah.
Okay. We'll come to this. I think you're right. I think the angle or the apical angle of the screw is important. I think a little bit of superior distal angulation, I personally don't feel makes a huge difference. I think if you purchase the tibia in the correct angle, so angling it from the fibula onto the tibia at a 30 degrees angulation and making sure that you're above the syndesmosis is what's most important.
Right. So should I go on to the next slide?
Okay.
Yes. I think I just want to talk a little bit about this fracture personality, please.
Yeah.
So this is the literature behind this this condition. It's called a Bosworth fracture. It was actually described after the Second World War. And that first line actually describes the fracture pattern quite nicely. What it is a posterior fracture dislocation in which the proximal part of the fibular shaft locks behind the posterior tibial tubercle. So what happens in this situation is the proximal part of the fibula blocks the tibia from falling back into its position. In other words, for the fibula to go back into the incisura. So it's typically reducible by close means because of the incarceration of the proximal fragment of the fibula. And of course, with multiple attempts at reduction, there is a evolving risk of a compartment syndrome. And you could even disrupt the blood supply to the AVN, to the talus rather, resulting in an AVN. So what is most important for us, I guess, is how do you pick up these Bosworth fractures when you first see them? And how do we not group them into a wider category of irreducible ankle fractures because of some other reason? So this is one of the things that's been published before, and this was by Andrew Sands' group back in 2000. They call the axilla sign. And I'll show this in the next view. But what you have is internal rotation of the tibia. So if you look at sorry, Kumar, you can go ahead. Yeah, if you look at the picture on the top left-hand corner, what you see is the shoulder of the distal tibial plafond, and that's called the axillary sign, where it is widened, and you see almost the entire submedial malleolar groove. And that is described as the axillary sign. Now, or the axilla sign, once you have reduced it, and that's the picture at the bottom central position, so that's image number 4, you still see subluxation of the talus in relationship to the tibia, and you still see that axilla sign, which is the widening of the shoulder of the tibia. And the reason for that is because the tibia is internally rotated in relationship to the talus, and that's because the fibular fragment is pushing the talus and preventing it from falling back into position. Can I show the next slide, Kumar?
Yeah.
So this is an imaging modality that is almost essential when it comes to Bosworth fractures. And why is a CT important? Of course, on the coronal slice, we will see the fracture fragments, and we see the tibia rotated internally in relationship to the fibula. But the giveaway here is the top right-hand corner image, which basically shows the fibula fragment and that fragment of bone of the fibula, which is actually blocking the tibia from falling back into position. So it's a bony incarceration of the proximal fragment of the fibula, which prevents it from falling back into position. And that's what that constellation of findings radiographically and on CT is what is described as a Bosworth fracture. Can I show the next slide, Kumar?
Yep.
So I suspected you'd ask me to summarize the learning points from this.
Yeah.
We could stop at this stage and discuss the X-rays before we go to this, if you prefer.
Yeah.
Shall we?
Please. You go ahead with. Yeah.
Okay. So I think my first take-home point with this is if one sees a fracture ankle that is otherwise should be reasonably easy to reduce, or at least reduce close to normal, but it's not happening, then do not repeatedly attempt close reduction. If you keep trying to do that, firstly, of course, you would compromise the soft tissue envelope, but worse still, you could potentially incarcerate damaged soft tissue structures like the EHL, the EDC, or even the tib post tendon, and cause progressive swelling, which could result in compartment syndrome. Of course, with this kind of fractures, if it is not a classic Bosworth, the other thing that we would all think about is some kind of soft tissue incarceration, which is point number 2. And of course, with this kind of injury, point number 3 talks about a syndesmotic disruption and a Chaput tubercle. So once the fracture is reduced and stabilized, then one has to stabilize the syndesmosis as well. The next slide, Kumar.
Yep.
Ah, sorry, that's it. Okay, I'll leave it over to you, Kumar.
Yeah, right. So any question, Dr. Rajiv sir, if you see the X-rays, or I'm asking the whole panel of mine to come up. Do you have any question with such X-rays and such fixation?
I think Gao has enumerated everything in detail.
Yeah.
Right. So we should go ahead with the second case. A deltoid injury and syndesmosis. So please go ahead. There I go. Yeah.
Thank you, Kumar. I'll make this a lot faster. I wanted to discuss this because I think the deltoid ligament is something that is becoming increasingly more topical, and we are actually recognizing it as an increasingly more important soft tissue constraint in the ankle. Can I have the next slide?
I'll just
go ahead. Yeah.
Bad habit of mine, actually. So the other day, I actually do agree with you, because the other day I was watching a webinar where Dr. Rajiv Shah sir was there and Dr. Mandeep Dhillon sir was there, and both of them agreed that the repair for deltoid ligament, the threshold for the repair of deltoid ligament is getting lower and lower. Is that right, Rajiv Shah sir?
Absolutely.
Yes, right.
Yeah.
So that was the point I wanted to make. Please go ahead now, Go.
Thank you. I'll have the next slide, Kumar.
Yep.
So this is a 23-year-old who sustained an ankle sprain about 4 weeks prior to seeing me. He had been seen originally in the emergency department and treated with a conventional RICE therapy. He had come in to see me 4 weeks post-ankle sprain with tenderness and discomfort beneath the medial malleolus. No true instability, just pain. So on exam, he had tenderness just beneath the submedial malleolus region. Tib post function in terms of single stance heel raise and tib post stressing was normal. He had reproducible tenderness by palpating just beneath the medial malleolus, and he had a full range of ankle motion. Of note, trying to reproduce or provocate the ankle for rotational instability was difficult because of pain. Okay. Can I show the next slide, Kumar?
Yep. There you go.
So I'll stop there, Kumar, and ask the panelists. So this is a 23-year-old with a 4-week history of ankle sprain, pain beneath the medial malleolus. Do any of the panelists have any initial thoughts on what the initial diagnosis is and how we should proceed from here?
Yeah, Dr. Rajiv sir, you want to take that question?
Yeah. Obviously I'm thinking in line of medial opening of the ankle, which could be due to deltoid injury. It could even be due to syndesmotic injury.
Right.
And further investigations would be deemed.
Yes. Yeah. Yeah, Rajesh Simon there. What do you think? Hello. Hello.
Yeah, sorry. With the X-rays, I don't think we can say further other than thinking about both deltoid as well as syndesmosis. Though the syndesmotic area looks little bit better with the tibiofibular overlap, and there's not much of diastasis seen in the syndesmosis. So with the X-ray, I would think more about deltoid, but you never know.
Okay.
So the next X-ray.
I'll just make a point at this juncture. For most of us, the commonest setting for presentation of a deltoid would be in the setting of a fracture. So it would be a ankle fracture, a lateral malleolus fracture, usually a supination external rotation with widened medial clear space. Now, the other setting would be a basic nerve type injury, where you would again have a high fracture of the fibula and a disruption of the intraosseous with the deltoid. But in this particular setting, I don't have a picture of the knee, but I assure you that there's no fracture that is high up in the fibula. But in this setting, it's unusual because you have a widened medial clear space, but no fracture. And that's actually relatively uncommon. And we see this sometimes in sportsmen. It's typically described as a high ankle sprain, where you have a disruption of the intraosseous ligament. And as the panelists have pointed out, really the question here is this a syndesmotic injury? Is this a deltoid injury? Or is it a combination of the two? And how do we actually distinguish the two?
Yeah.
I have the next slide.
Yeah.
So this is a lateral view. I apologize that the CT only shows one slice, but the rationale for the CT scan was actually to look at the syndesmosis and to see if there was any disruption or any translation of the tibia fibula gap. And I also scanned the opposite leg to see what is normal for him. Because this was a 4-week injury. And again, in the setting of a subacute deltoid injury, one does worry that the instability has been progressive. I'll have the next slide, please. An MRI scan was also done because the CT picked up an osteochondral lesion, and I wanted to ensure what sort of osteochondral lesion it was, the nature of the lesion, how deep it was, or whether this was old, new, was there any associated bone marrow edema. The other reason for the MRI scan was to look at other pathologies related to the deltoid. So is this a full thickness tear? Was it an avulsion injury or intrasubstance injury as Hinterman describes? I'll stop at that point. Are there any questions from the panelists or any comments?
So, I mean, are we trying to pass a message to all those who are looking at this case that we should go directly for the investigations? What was the clinical evaluation?
Yes.
What was the external stress test? What were the result of a cross-leg test?
Yeah.
So I would want to know clinical evaluation of yours.
Yeah.
And as well as before going to MRI, would you like to do some kind of specialized X-rays like gravity assisted view and all that?
At 4 weeks, doesn't matter.
So this is why I put this case up, because it opens a whole ballpark of questions. Let me address Rajiv's question first. So from the literature and from my practice as well, usually I would classify deltoid injuries into 3 categories. you have the acute tears, so the ones who we see commonly in relationship to a fracture. The second would be the sort that we are just discussing, which is a subacute injury. So these are patients who typically come in weeks or probably a couple of months after the injury. They usually have pain, and they may or may not have instability with an anterior draw where the talus extrudes forward, or rotational instability where the talus actually moves. And at 4 weeks, it's a little bit tricky because this patient in particular had pain. Every time you palpated that area or you tried to move the ankle, it was painful. So trying to provocate instability on a clinical exam setting was difficult. And that was partly the reason why the MRI scan was done. Now, in the view of other tests, like, as you say, a gravity stress view, or even a stress view, manual stress view, I find that those tests have very low reproducibility, and the sensitivity of those tests at 4 weeks in particular is very low. If you have an acute injury and you don't have access to a CT scan, I think those are very reasonable options. But I think in the general rule of thumb, clinical exam, if it can be done in a chronic setting, is the best way to examine a deltoid before you pick on examination. But in a setting where the clinical exam is difficult, then you would have to rely partly on imaging and the next step, which is a intraoperative investigative modality. And I'll show you what that is.
So we'll go on to the next slide.
Yes. So we just discussed this. What are the treatment options? How do you proceed at this stage? Is this there is an associated concern for deltoid, syndesmosis, and of course an osteochondral lesion as well. I'll have the next slide. So this is a picture taken in the operating theater with stress. And this is just to confirm partly that the medial clear space does widen with a external rotational and abduction view. And the tibiofibular overlap generally looks okay, even though it's very difficult to reproduce diastasis with just a manual stress view in a operative setting. I have the next view, Kumar. So I started off with an arthroscopy. Picture on the left side just illustrates the osteochondral lesion. Can I show the next slide? So this is where I want to stop at this stage. So I find that there are effectively two, if you like, best ways to evaluate syndesmotic instability. One is, we have already discussed, which is to do an open evaluation. And that is probably the best way to evaluate if we are doing something in the setting of a fracture. Visualizing the syndesmosis and ensuring that the syndesmosis falls back in, the fibula falls back into the incisura, and even pinning it if we need to is one way of doing it. This is the second method. And this drive-through sign, where you can admit a probe into the tibiofibular gap, is actually a very, not only accurate, but very sensitive way of picking up any diastasis that we see in a syndesmotic injury. Now, we talked a little bit about fibular translation in the case that Rajesh showed just now. If there is any concerns with the fibula being either too anterior or too posterior, again, with an arthroscopy, we'll be able to visualize this, because the relationship of the fibula in relationship to the tibial incisura will be very obvious. If the fibula is rotated or if it is coronally unstable, an arthroscopy is a very good way of evaluating that. So I started off with an arthroscopy to stress the fibula, the syndesmosis, to look for any instability. And I'll move on to the next slide, Kumar.
Yeah. So last one.
And finally, reconstructed the deltoid with this technique. I'm not sure if this is the best forum to discuss deltoid repair versus deltoid reconstruction and our role for when to do it and how best to treat the patient post-operatively. But this is what I did in this setting. I used the screw as a post and a suture anchor into the medial shoulder of the talus and reconstructed the fibula. The patient was kept in a cast for about 3 weeks and then converted to a boot for another 4 weeks after that. I think I'll stop at that slide, Kumar. I'll open it to the panel.
Yeah, true. So we should keep an eye on the watch as well because it's already 6:30, but we have 2 or 3 more presenters already. So moving quickly, the good message that you are giving is that we should think of deltoid reconstruction in such cases. Because see, this webinar of Bihar Orthopedic Association, most of our viewers may be a general orthopedic surgeons who are also encounter such cases in their day-to-day practice. So it is very important to understand that foot and ankle injury can have entirely a soft tissue injury which requires surgery. So if there are no fractures there and you see that kind of tear space and this kind of finding is there, not many arthroscopists are there here, but definitely they could see from the X-ray, from the clinical examination, as Dr. Rajiv Shah sir is rightly stressing again and again that clinical examination is of paramount importance. So if such thing is there, we may require to do a soft tissue repair. Rajiv Shah sir, your comments, please.
Yeah. So, yes, Dr. Go, you won the battle by doing the arthroscopy. I would have done it right away for this case, but obviously not for the case which you demonstrated before. And my message to all those orthopedic surgeons who are not a routine arthroscopist is that you can put your medial incision a little anterior and you can have look into the joint, because some series came up with 68% chances of having osteochondral injuries with the ankle fractures. So, yeah, but the only small question I wanted to ask to Dr. Go, had this patient presented to you on day 1, what would have been your management? And this is the message I want to give to every orthopedic surgeon who is attending this.
Thank you, Rajesh. So I think that's a great question. I guess another way of phrasing your question is, how does one manage an acute deltoid injury? And I think the way in which we manage an acute deltoid injury is two-pronged. Conventionally, if we go back to the papers from Michelson, and even if we looked at Campbell's orthopedics, it is always broadly divided deltoid into stage 1, grade 1, grade 2, and grade 3. And if you have a grade 1 injury, then you treat it as a sprain. If you have a grade 2 and a grade 3 injury, you want to actually immobilize the patient and non-weight bear them for 8 weeks. Because if you immobilize and you allow them non-weight bearing, then the ligament scars up. Conventionally, when we used to do ankle fractures, we were always told, don't repair the deltoid because it will heal up and it would scar up. But what we used to do differently in the past is we used to immobilize them and non-weight bear them for 6 weeks at least. Now, with the newer philosophies of thinking, we start to immobilize patients at a very early stage. And so what's happening is, if we don't fix the deltoid and we start mobilizing the patients at 2 weeks and start fully weight bearing them at 5 weeks or 6 weeks, the deltoid does not have a chance to heal. And so what happens is the patient then starts developing a valgus sag and pain over the submedial malleolus at 2 months, 3 months, 6 months, and I see them even at 9 or 10 months. And the reason for that is because the rehabilitation that we are now employing for ankle fractures is not conducive for non-operative treatment of a deltoid. So in summary, Rajiv, I think the answer to your question is, if we're going to mobilize the patient early, we should fix the deltoid. If we are going to keep the patient and treat them non-operatively, then we should do it with 6 weeks of cast treatment and non-weight bearing.
Right. So
Can I say something very quickly, Kumar?
Certainly, please go ahead.
So in these acute deltoid associated with the fractures, Gao, do you go and routinely repair them?
Yes. So I typically find that with the ankle fracture cases, it's usually, not always, but usually in a high energy, usually a Weber B or a Weber C. I usually use that as an excuse to scope the ankle, and I repair them and as an all inside technique arthroscopically. using all inside suture technique.
Right. So for the benefit of the general orthopedic surgeons who might encounter this problem,
Yes.
a medial incision slightly bit more anteriorly placed. Most of the time, as I'm sure you know, the deltoid comes off from the medial malleolus. And
yeah. So
so it's easy to just perhaps using some anchors to stitch it back onto a denuded surface of the medial malleolus, because in the long run, as you mentioned, they continue to have pain on the submalleolar area, but eventually, due to the valgus deformity, they develop tip post dysfunction as well.
Yeah.
That's one of the things you'll find in patients as you follow them up after a year or so, that missed deltoid ligaments or untreated acutely deltoid ligament will eventuate in a tip post dysfunction as well.
Yeah. I think you're absolutely right, Arvind. The sequelae to leaving a deltoid insufficient is something that we have accepted for a long period of time, but is now becoming more obvious. The question of whether you repair or reconstruct a deltoid ligament is still open to debate. I think there's no gross evidence to say how you treat the fascicles. In fact, even anatomically speaking, we still can't agree on how many fascicles there are and whether it's just superficial and deep. But one of the advantages I find with arthroscopy is you get to visualize that avulsion of the submedial malleolus, and you get to put it back to exactly where it is. Now, I have gone from being slightly more conservative by putting them in a cast for 3 to 4 weeks to now putting them in a boot. But I still don't get them to range the ankle for at least 5 weeks, even after I have fixed the deltoid arthroscopically.
So, right.
Thank you.
Thank you so much. I think before we wrap up, there's a question from audience, which is for Go. So rather than me answering that question, you're the right person to answer that. The question is, what implant do you prefer under a reconstruction deltoid ligament versus repair of deltoid ligament? Probably the questioner wants to know what different implants do you use for reconstruction versus repair?
Yeah, so I'll keep that short. If I was doing and it depends on whether it's an acute, subacute, or chronic injury. Now, if it is an acute injury, I've just described, I do it arthroscopically with a all-inside suture button technique. If it is a chronic injury, what I have had to do in the past is either use a tendon allograft or a autograft to actually recreate the two fascicles, the anterior lip and the posterior lip of the deltoid, to try and get that balance completely right. Now, the two people who have probably published the most on this is Eric Blumen and Steve Haddad. And the techniques, I think, vary a lot. In this particular setting, I used a augmentation, really, of the deltoid using the suture button technique, but I also repaired the deltoid with an end-to-end repair. So I think the jury is out, but the implant of choice depends on whether it's an acute, subacute, or chronic injury. And that goes from suture button all the way up to an allograft or an autograft.
Right. Thank you so much, Gaurav. So I think we should move on to the next speaker, next presenter, who is none other than our own Rajiv Sasser, a doyen of foot and ankle surgery in India, who has taught each one of us the modern ABCs of foot and ankle. So Rajiv Sasser, none better than you, to show what went wrong and how to salvage. Dr. Rajiv Sasser.
Thank you very much. And this is a great opportunity to meet my friends, Dr. Go and Dr. Arvind. And I'm going to move away from ankle because a lot of discussion has gone into ankle. So I'm going to go to a case where a female 26 had a twisting injury, and obviously diagnosis Kumar is in front of you, but I would like to involve Dr. Rajiv Anand, that how would he manage this patient?
It's I feel it's a typical Jones fracture. And
Okay.
is how old he is given? It's acute injury.
26-year acute twisting injury.
Acute twisting injury. Yeah, right. So I'll definitely go for conservative treatment for this case.
Okay. What would you give? Would you give a plaster?
Yeah,
Full
plaster
plaster, short plaster?
below knee cast with a neutral
And
plantiflexion.
plantigate position.
Yeah.
Dr. Arvind, his mic is mute.
Hi, Arvind, are you there?
Yeah, I'm
His
here.
mic is
I was just, the mic was mute. If she is an active person, right, sports, and is involved in a job which involves her to be on her feet or do a lot of heavy work, I would probably suggest that I go in for a open reduction internal fixation for this fracture.
Dr. Go.
So Rajiv, I think it's a patient information decision. I would tell the patient that non-operatively, there's about a 92% chance of union. Operatively, fixation with an intramedullary screw would get the union rate a little bit higher to about 96%. But it also means that the length of time for early rehab becomes shorter, and the patient can decide which option they want to go for.
That's great. Kumar, what would be your option?
Yes, thank you for asking, sir. Preferably, I'll go for surgery, but I can see that in my practice, more often than not, I end up managing such case conservatively, and I have seen that they do reasonably well.
Okay, so this patient was managed conservatively and a plaster was given, a full below knee plaster was given, and that plaster was given for about 4 weeks. Removal of the plaster, patient had persistence of pain. So patient was given another plaster for 3 to 4 weeks. So patient was given 2 plaster casts. It was asked to walk. 5 months X-rays, pain was persistent. Dr. Rajesh Simon.
Well, the trial of conservative management it has finished. I probably wouldn't have waited so long. It is the fracture does not show any signs of any union there. You can see the margins are kind of sclerosed. It is gone for it is. I mean, you cannot brand it as non-union yet, but it is going towards non-union. So I would think nothing other than an intramedullary fixation and freshen up the edges. I don't know about bone grafting. I wouldn't be thinking about that now. But yes, I would go for a fixation now.
So the question to panel, when do you primarily advise surgical intervention to the cases of John's fracture? Starting from Arvind, Go, Rajesh Simon, Santanu.
So my indication, Rajiv, for fixing these fractures is dependent on the age, activities, and profession of the person and their expectations. If they are young, non-smokers, very active sports, I would offer them primarily a fixation. If they are a bit middle-aged or they are inactive young people who are certainly not going to be that reluctant to undergo surgery, then yes, they can have some plaster put on. But I'm very low threshold to go and fix them if I find there are no signs of union coming close to 8 to 12 weeks time.
Dr. Go.
I think I agree with Arvind. I think the time duration, certainly the literature, at least for elite athletes, is about 16 to 20 weeks. So I think I wouldn't wait beyond that. The only thing I would add on, Rajesh, is this is looking a little bit like a stress fracture. And I would worry about the shape of whether this is stable, is there a lateral column overload,
Sorry to interject,
and address those issues.
Marshall, you need to mute your speaker. That is causing a lot of disturbance in the audio. Samshul, you need to mute your speaker. Yeah, please go ahead, go. Sorry to interject.
Yeah.
Please go ahead.
So he made a great point that all these patients should be clinically evaluated for presence of heel varus and repetitive lateral ligament instability, history of lateral inversion sprains. Because if these patients, they have a heel varus pre-existing or history of repetitive ankle sprains, then they are the candidates who together with the athletes should be offered surgical intervention. So this was the point I wanted to bring out.
Yes.
Rajesh or Kumar, would you want to add something?
No, I'll just put in the perspective of practice in my state, because what we encounter here in my city and most of my state is that people end up doing it conservatively. But as rightly pointed out by previous speakers, I would like to fix it, especially when there is heel varus and there is lateral ligamentous laxity. But if I have to tell you very honestly, I maybe only fix 20% of such cases. Rest of the time, then do not agree for surgery. They want to be treated conservatively.
Okay, so answering to this question, and that is why I brought this case.
Yes,
Suppose you want to treat John's fracture conservatively. Can you really treat John's fracture conservatively? And this was the question which was asked to us in AOFS meeting to come up, and now anyway, this is what was done for this case. Bone grafts from the calcaneus were taken, and bone grafts were pushed in with this kind of 3 MIS incisions, and a screw fixation was done, and patient ultimately went on to healing. But this was a question: can you manage John's fracture conservatively? Many of our patients, they do not agree for the surgery, or it is not possible to operate them in a given setting when we really advise them. So this was a study which we presented in AOFS 2016. They wanted me to come up with a study of conservative management of the John's fracture. And so this is what was the protocol we followed. First, Pilon non-weight bearing plaster in a neutral dorsiflexion plantar flexion, but with eversion. Eversion to really neutralize the pull of plantar fascia, pull of peroneus brevis. So this was the first plaster given for 6 weeks in eversion. And then second plaster was a walking plaster, which was a short plaster into a neutral position like this. And then this retrospective study, 23 cases with the average follow-up of 6 months, we found that people can really heal provided these kind of protocol is followed. Obviously, sportsmen or myself, if I have this kind of fracture, would not like to undergo a conservative management.
Yeah.
So even if you want to treat patient conservatively, mind you, these cases take a long time to heal. Radiological union is delayed than the clinical union. So go on evaluating your patient, and if required, give a longer immobilization. That is the message I wanted to give.
So my question here, before we move on to the second case, my question, sir.
Please.
Yeah, my question is, like in my own practice, I encounter many such cases where I have advised surgery, but patient come back, having not been operated, ready for being operation, they come back and they show that there is non-union. So do you do surgery in all of them, or you let few of them go without surgery?
No, all those non-union symptomatic patients, they require surgery.
Right.
My question to Dr. Rajiv Shah, sir, when you see a non-union and you see an accompanied problem in the foot, like do you also address that in the same setting?
Absolutely great point to be brought, because unless you address the reason or the cause of the problem would come up again. So That is what was my first point, that you need to assess your patient clinically, that whether this patient has got something which is making this patient more prone to get the fracture. Patient has got a lateral column overload. So you also need to side by side treat the same.
But
Right.
one thing I would like to ask, sir, in our practice, so many Jones fracture cases, we go for 6 weeks cast immobilization and they are well after the 6 weeks of duration.
I
So
agree.
so do you think that we should tell them for operative procedure to undergo?
All those who are one, active, athletic, who want really to go back to the sports, one. All those who have got some biomechanical abnormality, two, they should be offered surgery.
Yes.
All those who are active adult, not athletes, they should be counseled, like Dr. Gao said, that yes,
Yeah.
there are chances of you to get this fracture healed with the conservative management, but there is an availability of the operative management which has got a better success rate. And the third point, that if we are treating conservatively, we need to immobilize them longer. Out of our 24 cases which we treated conservatively, 23 went on to unite. So that was the message I wanted to convey.
Sure.
Great, sir.
Okay, so this is one of the very common presentation I wanted to bring to everybody's notice. This was a 4-week presentation of male, 27. He had a history of road traffic accident. Dr. Rajesh Simon, your diagnosis and what next?
I can see a fracture of the medial cuneiform. I can see a little bit of a diastasis in the first web space. So the medial column is definitely involved. There is a Lisfranc injury.
Yes.
Yeah, with the existing X-ray, I think I can comment on that. That is a Lisfranc complex injury of the foot.
So, Dr. Kumar, we notice this quite often in our practice. So, if you can summarize that, how not to miss the Lisfranc injury in an acute setting.
Right, sir. So you have to first of all go with a very high index of suspicion. So I'll again quote the line, high index of suspicion, number one. Number two, clinical examination. Number three, when you look at the X-ray, you have to understand that in the AP, foot, AP and oblique view, all those signs were, yes, in the, in this X-ray, the medial border of the first metatarsal should be aligned with the medial border of the cuneiform. The lateral border of the first metatarsal should be in line with the lateral border of the medial cuneiform. The medial border of the second metatarsal should be in line with the medial border of the middle cuneiform. The lateral border, the medial border of the third metatarsal should be in line with the third cuneiform. There should be no flex sign there. And fourth, in the lateral view, in the oblique view, in the internal oblique view, which we can see here, the fifth metatarsal articular surface should not be too far away from the cuboid.
So great point, and one important point.
One most important point I would also add on is the weight-bearing view. If possible, 4 weeks, I would definitely go for a weight-bearing X-ray. And I think this is something which in all the foot and ankle conferences today, I always say, if there is one point, if you want to take back home, please start doing weight-bearing X-rays for all your foot and ankle cases, like what you do with the knee. For here, this would be very easily identified if you have a weight-bearing X-rays.
Yes.
I'll just add to that, Kumar. I do a stock view. So at 4 weeks, they can usually stand on their tiptoes. And that actually accentuates the dorsal sag as well. So if you take a direct lateral view, you can see the sag a lot better with a stock view, which is again one step more than a weight-bearing view.
Okay.
Yeah. And there is something like plantar ecchymosis. When you look at this
Acute
case,
stage.
in an acute stage, you do see plantar ecchymosis present.
Yes.
So, Dr. Arvind, this is quite a common scenario in our country. How often do you notice it in Australia? And at 4 weeks, such a presentation, what would be your line of management?
So, Rajiv, I think this is fairly common here as well. And you'd be surprised how often it's missed and how often we have to see patients who have come weeks and months down the track. So if you have somebody who's got an acute injury, you can stabilize the Lisfranc. And again, it's up to you whether you like to do it with screws or you want to use some sort of new modern tightrope kind of implants. But in my hands, I still follow the traditional way of stabilizing it. I open it always. There's no percutaneous reduction of these. So I open them always through a dorsal incision, clearing the scar tissue between the two, reducing it, fixing it with a screw. The only thing I do differently now is, rather than the traditional way of introducing the screw from the medial cuneiform to the base of the second metatarsal, I go the opposite way. It's a lot easier for me to do it. And then, of course, you have to also remember before you have gone to do this, that you have clearly looked for other injuries which could be associated with this and whether they need some addressing or not. For those who present too late to me, Rajiv, I just go and fuse the second, third TMT, whichever is needed. And if the first ray needs to be immobilized, I can put a spacer plate and immobilize that for them. So I still follow the old way of addressing this, but my threshold for fusing them, the second, third TMT, is pretty low. I'm very easy and quick to do them because I find they have a much more predictable outcome.
Okay, Dr. Go, at 4 weeks, what would you go ahead?
Agreed. Fusion.
Fusion. Dr. Rajesh Simon, 4 weeks.
I don't think at 4 weeks you should even try salvaging because there is good amount of damage that is done if the patient has been mobile. So I think yes, fusion for me too.
Dr. Kumar?
Fusion. Actually, sir, in this particular case, the Lisfranc element is even more of ligamentous thing. Probably I would have thought of if there had been no cuneiform injury, I would have gone for fusion even primarily. But here, definitely, I'll go for fusion.
Okay. So that was what I wanted to give a message through these missed cases, that these cases are quite often missed. We presented our study of 482 foot and ankle injuries in a journal of injury, where 33% of the missed cases were Lisfranc injuries. So maximum cases which were missed were Lisfranc injuries. So as Kumar said, high index of suspicion, plantar ecchymosis, clinical evaluation, standing x-rays would really save us from missing this. Kumar, your turn now. You want me to show third case or?
No, third case, sir. No, there are questions. I was just reading the questions.
Okay.
I'll ask you a quick question, Rajiv, while Kumar is doing that. Fusion in the setting of a Lisfranc diastasis like this, is it any different from a normal fusion for degeneration?
Yeah, absolutely, because you have to go in with a kind of good release and removal of the tissues, and you sometimes really have to do opening of medial ray, middle and first ray, second and third initially before really doing the reduction. Otherwise, sometimes you really don't get the reduction. So for getting the reduction, you would have to open the medial side, the first TMT, you will have to open second and third and go with the second fixing of second with the medial cuneiform with a screw. And I would like to always go with the plate fixation.
If it was an acute setting, sir, would you still have gone for fusion or would you have gone for fixing?
No. Even in a chronic setting, I would up to 4 to 6 weeks. In a young patient like this, I would like to go ahead with a counseling of the patient that if on exploration I feel that the joints are looking pretty good, I might go ahead and do just a fixation than the fusion. But in an acute setting, obviously I do fixation. And if you go and look at this study of a study which a landmark study which said that the fusion should be preferred over fixation. In a personal setting, the same observer says that no, this paper was misrepresented and misinterpreted of going ahead with a lot of fusions over fixation. It was specifically made for certain athletic individuals where a fixation was deferred and fusion was preferred.
Right. So I am ready with the questions. I am very glad and grateful to my viewers who are coming up with great questions. So I have a question from none other than our very good friend, Dr. Hitin Mathur from Delhi. Dr. Hitin Mathur. Hello.
Go ahead. Go ahead.
Hello.
Yeah, go ahead. Go ahead with the question.
Right. So the question is to you, sir. The question is, did the Jones fracture patient have a cavus high arch foot? This is the question to you, Dr. Rajiv, sir, where you have presented your X-ray. So
no, that patient had no cavus or high arch foot. No.
Right. The second question from Dr. Hitin Mathur is, do all non-united Jones fracture need surgery? Some in elderly are asymptomatic with non-unions also. So probably we have answered already.
I already answered.
Yes. The third question is from him, and that is, what about comminuted Jones fracture? Will you apply a plate or a screw? I think plate.
Plate.
Yes, sir. So those three questions were from Dr. Hitin Mathur. There's another our viewer, Dr. Mahesh Ladumor. So he has asked me, I'll have to go a little back, but since it is a question from here, I'm duty bound to take it. The question is, to Rajiv Shah sir, summarize treatment for deltoid tear, when to operate and when not, and what is the conservative protocol? That is the question. I think much of it is already answered, but your quick and short response to this question, Rajiv Shah sir?
See, for a deltoid ligament, which are mild to moderate deltoid ligament injury, you can really get out with. And what I do in my practice, I immobilize them into little more of inversion, and I apply a plaster splintage for 6 to 8 weeks. So that's what I do. Nowadays, I have been more and more towards fixing the deltoid ligament injury. But for you, if you really want to treat conservatively, immobilize them 2 weeks more, and you might like to immobilize them into inversion.
Right. So some other questions. Did somebody say chai?
Yes, I heard so.
Yes, we could do with some chai, certainly. But we have got to take the questions first. And there's a question again from Dr. Pradeep Munath. And the question is about, just give me a moment, sir. I have seen few patients with heel varus with Jones fracture, and they are happy to go ahead with fixation but are not ready for calcaneus osteotomy. What is the panelist's opinion regarding this? I'll repeat the question. I have seen few patients with heel varus with Jones fracture, and they are happy to go ahead with fixation but not ready for osteotomy. What is the panel opinion?
Yeah, so if that is a scenario, I know Pradeep is always able to convince patient better than us. But still, if that patient is not getting convinced, I think you could go ahead with an permanent kind of a utilization of orthotics for that patient, so that you can really prevent repetitive fractures. And that is the only answer.
Yes, the other point he's making is about this Miss Lisfranc. He says that up to 6 weeks, orifice better than fusion. He has reviewed the literature yesterday. That is from Dr. Pradeep Munot. Who's on the panelist?
So this is going to be another 2 hours of discussion.
Right. Yeah. You had another case, sir, which I had noted down. That is missed midfoot dislocation. Do you want to go ahead with that, sir, Rajiv, sir?
I do not know whether we should be going ahead with this case or not.
Right. Okay. So in that
We
case,
have time?
I'll do a short presentation of my own, if you all allow me.
Yes,
Shantanu
yes. Go
sir,
ahead.
there is one more question from Hiten sir. I'm messaging the group.
Okay. So you can ask the question, please.
Sir, Dr. Hiten Mathur has asked for Lisfranc, is your decision for fusion versus ORIF guided by activity level and whether patient is an athlete besides level of communication?
For me, it is the damage to the joint. It is the intraoperative damage to the joint. That is what makes my decision making, at least at 4 weeks. Let other panelists opine.
So on the topic of athletes, so my conventional way of stabilizing the Lisfranc is with a tightrope and 1 screw. So that's my conventional fixation. The tightrope goes from base of second to middle cuneiform. The screw goes from middle cuneiform to middle cuneiform. But in an athlete, I typically use a plate because I find that, and I tell them that they need a plate removing because it's extra articular and there's less risk of damage to the joint. And I find that they often have a bit of a dorsal sag, not always, but a bit of a dorsal sag, and the plate acts as a good buttress.
You fuse at that time, and I mean, you don't fuse. That means what you say, that is what you said.
No, I think that the question of fusion and versus repair or reconstruction is still the same, whether they're an athlete or not. But in the athletic population, in the acute setting, I treat them a little bit differently from the non-athletic population.
So I would like to show a case of missed fracture myself. Let me see if I can get it going. Right? Can everybody see my?
Yes.
Right. So this was a case which I had to encounter way back in 2015. I'm not using any new case, and that is purposefully so because many of my colleagues here in Bihar are still at that particular stage of foot and ankle surgery where we are learning the ropes. So this was what I had in 2015 or 16. There was a case of neglected Cotton's fracture. This was a 40-year male presenting 65 days after injury. Now, there was another X-ray with him, which was taken 3-4 weeks after injury. So that was about 21 to 28 days after injury. But hang on, there was another X-ray. This one. This was the first X-ray which was taken on the day of injury. Now, if we can see, the patient from top left to bottom right came just because of some neglect, mostly on the part of treating physician and also a little on his part. The excuse why nothing was done so thus far was there was a wound anteromedially. So he was advised just a below knee slab and regular CNB. He was probably told that once the wound heals, then only we'll have to do something. Now we are encountered with this situation. Now I would like to have my panelist view, starting from my friend Arvind. What would you do in such a case now?
Oh, it's again a very, very difficult case, Kumar. It's already 2 months and it's been dislocated like this for 2 months. He's a 40-year-old guy. Now, depending on his general health, if he's got any risks attached to with his comorbidities, what his profession is.
He was actually a laborer with no history of smoking, no history of any significant smoking, probably none at all. And he was non-diabetic.
So I personally, in my hands, would find the one operation this patient would need would be an ankle fusion.
Right. Okay. And Rajiv sir, Dr. Rajesh Saman, Dr. Go, you guys, please come up.
I think in India we do quite see more probably often this. What I believe is this ankle is salvageable, and I would not think ankle arthrodesis is the first choice. Of course, this was in an acute setting. I would have definitely gone for an external fixator. I would never have agreed on a plaster. Plaster is invariable. It's a highly unstable injury. So there is absolutely no role for wound debridement with plaster. It has to be external fixed. So
Yes.
that is the first point.
Yeah.
The second point is now if the patient has come with the wound at 2 months, I would still do the same. I would again, if there is a wound, does the patient has a wound now?
No, no wound at all. The wound is completely healed.
Wonderful. So that part of thing is taken care of, but the ankle is disrupted again. So I would again try to do a distraction and try to reduce the ankle first, and then plan out my my fixation. Fixation would be standard, but I would not think about
Hang on. Now the question is, before we go for what fixation we are doing, there are two views here. Arvind said fusion and you said salvage. So probably I'd like to have the views of Go and Dr. Rajiv sir as well on this. So Go?
Yeah, I agree. I will salvage this.
Okay, Rajiv sir?
No question, I'm going to salvage it. 40 years old male, just 65 days old injury.
So, but you need to understand, all of you, that the duration now already is 65 days. Even if you salvage, do you think the cartilage and everything is the articular cartilage will be good enough for the patient to have a long-lasting working ankle joint?
There is a paper. I think there is already a paper on this. In ankle, it does not matter. I don't remember the exact paper, but it doesn't matter how long. You can still do it, and you can salvage the ankle.
Paper says that they could salvage ankle at the end of 7 years.
6
of
years.
the tomb. 7 years of the tomb. So I think salvage is always an option. Arthrodesis can always be done at a later date. 40 years male, we would like to salvage the ankle. And how many of this we have been doing in India? We do it at the end of 65 days or less. We do it at 7, 8, 10 months.
Yes.
So my point is, you want to give this man one operation, because you cannot salvage this ankle in one surgery. It has to be staged, you know, and he's a laborer. He lives in India. He's 40 years old. You want to get him back to his feet quickly to go back to work. And I think an ankle fusion will be the best bet for him.
If he lives in Australia, what would you do?
Ankle fusion. If he's a laborer and he wants to get back to work, that's what he gets.
I would still differ on that, because in India, our laborers would like to squat, and giving some good movements to ankle is always very important.
And arthrodesis is always available to you. See, it has also happened that surgeons have gone in with the thought process of fusion, and then they found that cartilage was so good.
Yeah.
So, all right. So I'll show very quickly, I'll show what I did, right? Hello, are you there?
Yeah, go on.
Yes. Right. So this is what I did at the time. I put the patient on actually a calcaneus traction because everything was so contracted. I was not very sure that I will be able to really reduce it. I actually wanted to salvage it myself. So I initially put the patient, really to err on the side of caution, I put the patient on calcaneus traction for 7 days, then I did an ORIF. And this is what I did. Now this I did in 2015. Probably today I'll do something else. But at the time, this is what I did. I fixed all the 3 fractures. I was very grateful that I was able to get a very reasonably good congruity of the joint. And I was a little modified whether I'll really lose the reduction or something, I put a few keywords from down up. And then after 4 to 6 weeks, I removed the keywords. So this is the picture after 6 weeks. So comments from Rajiv sir.
Is
So
it,
it reminds me of my first case of ankle malunion when I operated.
Yeah.
That the reduction was not so good. And
Yeah.
then I put in 2 such pins. I did the same thing. I put in 1 ST pin. Instead of 2 pins, I put in 1 ST pin.
Okay.
And if you see the X-ray of that patient, and when the X-ray of that patient was shown in a meeting, everybody opined that this patient would require fusion. And then my next slide was the movements he got. Excellent movement on the side where she was operated, ankle was reconstructed, and the other limb was hemiplegic limb.
Okay.
So to salvage the movement of the limb, which is good limb, and still that patient, even after 7 years of the reconstruction, though X-ray do not look so great, is doing fantastically fine. So you've done a good job.
Yeah, and it is at 16 weeks. But here is the point which Arvind was making. I could see some reduction in the articular space, joint space. So your comments on that, sir?
The radiological arthritis will not correlate with the clinical symptoms and signs.
Right.
So you have to look at the clinical scenario.
Yeah.
So what were the movements of the patient? What were the complaints of the patient? Don't go on the radiology.
No, the patient's movement went much. And he used to complain of pain. So at this time, I really lost him actually. And I remember that way back in 2016, he again came and I advised him fusion. And he was none too happy that I have already done an operation and I am telling him to undergo another operation. So he was a little miffed at me. But that is what happened. And I really wanted to share this story with you all and with all my viewers that we started from here actually, here. And when things are not done in a proper way, even after a lot of effort, the patient will not be too happy at all. So that was the thing I wanted to tell.
Yeah, even in my experience, like malunited late cases, they look good on X-rays, but they always complain pain. And we have to convert it into the arthrodesis again. So that's the point,
So that is my question to all my panelists, Arvind, Gau, Dr. Rajiv sir, and Rajesh. How many such cases you need to really go ahead and do a fusion?
So can I just say, I went to a meeting in South Korea about 3 years ago.
Yeah.
And there were delegates from Korea and China and other places, and they were doing a lot of distraction arthroplasty for patients who had issues with their ankle arthritis to try and preserve their joint for as long as they could to give them mobility. But when you really ask them specific, incisive questions, they all acknowledge that most of the movement that was coming from their midfoot. Their ankles were pretty stiff and they were sore, So really, in my mind, you have to really think of the patient as a whole. He's a person who's got social responsibility, jobs, families, money to think about. You really have to take all that into account before you decide what you want to do. We all love to salvage stuff, but when you look at a patient and say, this guy will do better with one operation, back to being to his as close as he can, his normal routine, that is what you need to give to the patient.
Right. So that again brings me to my question, which I had put is, what percentage of such cases you need if you are going for salvage, Rajiv sir and Gau and Rajesh, if you are going for salvage, what percentage of cases you'll have to go back and do fusion?
So at least I have started salvaging ankle from not so long. So my experience of salvaging ankle is from last 6 or 7 years. At least one which was having some kind of infection, low grade infection came in for the fusion. The rest all, they are all doing well. But then it's a personal observation, not a study published.
Okay, right. Rajesh, you?
To be fair,
Sandhu sir, sorry to interrupt. We have to wind up by 7:30, sir.
Okay, we will. How much time we are left? Another 5 minutes. Okay.
5 more minutes. So I think
Another webinar in queue, sir.
right. So I think to answer the question, I would probably today we have an MRI, we would have a scope. So if there is a good cartilage, I would always try to salvage. I don't have the numbers to say the percentage here, but I would like to salvage as much as possible. But I would definitely look at the cartilage with an MRI, or if not with a scope, and then decide whether I can salvage. If I think in day one the cartilage is all gone, the joint is badly affected, it's a neuropathic foot, it's a very badly osteoporotic foot, then yes, I'll go for fusion. Otherwise, I'll try to salvage.
Right. So I think we'll have to wind up quickly. So there was a case to be presented by Dr. Rajiv Anand sir also. I think we can go on to that. But before that, the message I wanted to give my viewer is that if you are encountered with such things, don't let it come to this, because after that, there will be not too happy scenario. We must try to salvage, and many of the cases stay salvaged, but few of them which may require fusion, we have to go ahead and do the fusion surgery, right? Hello?
Hi. Yes, you stop
Sharing the screen.
sharing the screen.
Okay. Just a moment. Stop sharing. Right. Okay. Right. So Dr. Rajiv Anand, sir, your case, very quickly, 1 or 2 slides.
Yeah. I'll just end it in 5 minutes. Can you see my?
You have to share the screen, sir.
No, I have your case already with me. If you want, I can show that.
Yeah, you can show that. I think.
Okay, all right.
I'm not able to share.
We are running short of time, sir.
Yeah, so I think we can wind up now, Shantanu.
So we can discuss another.
We can wind up.
Sir, Rajesh, we can discuss your case. 2 minutes, sir.
Yeah, very quickly, I'll just discuss the case. So this is a 20-year female sustained a road traffic accident. It's a closed injury and a lot of swelling. I'll just ask the panelists, like by looking at this X-ray, like do we need some more investigation or not?
CT scan, I guess.
CT scan is needed. But why did I did a mistake? I didn't go for a CT and I just went off. So, but what I found in my OR that it's a lot of comminution was there, and it was very difficult to reduce it properly because of the comminution and all. And I have to go to anteromedial incision to just look at the joint and all that, whether the joint is congruous or not. So my only message is that in such a cases, that the first X-ray, that you must go for an CT as well. That's what I wanted to. So any comment from any panelist?
Yeah, see, this is the case where you see double medial malleolar sign.
Yeah.
So this is the case where you have a posterior medial posterior malleolus. And so unless, I mean, it also is seen on the X-ray, in CT scan also it would have been shown very well.
Yeah, right.
You should have gone with a posterior medial approach to fix it and put in a plate on that side.
Right, sir. Right. So I think Samsul, do we have time to?
No, sir. We have to wind up, sir.
Yeah.
Okay. Anyway, so I think there has to be some comment from our president, sir. A vote of thanks from him, maybe.
A vote of thanks will be given by Dr. Rajiv Anand. I have one comment to make, that the AP and lateral X-rays are occasionally deceptive. So CT scan is a must, and that is very helpful. So I hand over to Dr. Rajiv Anand.
Thank you very much. Thank you. Thank you so much. It was a wonderful webinar. And I've never seen a webinar who was fixed up for 1.5 hours and is probably 2.5 hours. So it was a very wonderful interaction. And I really sincerely thanks all the panelists, Dr. Arvind, Dr. Rajiv Shah, Dr. Shantanu, and Dr. Rajesh Simon. Everyone, thank you very much. And I think the number of viewers must have gone to 12, 13, 1300, I probably.
So we have more than 1,500.
More than 1,500. So it's a big congratulations to Shantanu as well. He has moderated it so well. And on behalf of Bihar Orthopedic Association, once again, I thank all of you, including those viewers, 1,500 viewers who were with us today evening. Thank you so much.
Thank you, Kumar. Thank you.
Thank you.
Thank you, sir. With permission of chair, I'm just stopping the live session. We can continue on Zoom.